Welcome to Long Term. This podcast, the journey that we've taken along the way of learning about recovery, we've covered so many different areas, but there's still, it seems like no matter how much terrain we cover, there's still just miles and miles and miles and miles of all types of terrain to go. And there are mesas, there are valleys, there are mountains, there are rivers, there's huge unexplored areas of this that I think it just seems to be endless. I don't know if we'll ever cover the entirety of what recovery is or what helps, because we find more and more that there are solutions that are sort of revolutionary and new things that are being invented all the time, new programs that are being adapted. There are new medications that are coming out. And so it's always exciting to talk to the experts in the field of what's new, what's coming out, what is the future of recovery, what reducing the harm of somebody that is in addiction. How can we do that? And so it's always a pleasure to talk to somebody who's a professional in their field. Like today, we have Paul Kolodzik, MD, who is board certified in both addiction medicine and emergency physicians. He's one of the few physicians in the country utilizing GLP-1 medications, and we'll definitely get into that, as well as other FDA-approved medications to reduce alcohol use. Over 30 years of emergency room career. I mean, like you have a reputation for yourself, I would say, in this field.
Yeah.
Yeah,
Thanks
yeah,
for having me, Ty. It's a
no
pleasure to
problem.
be here. So, yeah, my addiction interest kind of grew out of my emergency department work, and that initially involved the scourge in Southwest Ohio. I live in the Dayton, Ohio area, with the fentanyl issues back in the mid 2000s or so. So, I opened an addiction medicine practice, primarily serving opiate addicted patients, and I still treat a number of those patients. But my alcohol practice has grown as well, as I've used FDA approved medications to help reduce alcohol use. And now the GLP-1s are out there, and we're having great success at helping people reduce alcohol use. My approach is a little bit unique, and as we talked beforehand, people have strong opinions on this. But in the emergency department, I've seen a lot of times the cycle of people doing well in recovery, but then relapsing, binging, and kind of going through that cycle over and over again. And so I've got interested in the concept of harm reduction, and harm reduction really is decreasing alcohol use and then helping people if they want to go on to abstinence. I support that. But a lot of people that come to me actually realize that they're just drinking too much. They don't necessarily want to quit drinking completely. They just want to significantly decrease the amount of alcohol that they're drinking. And so I help them do that. That's called a harm reduction approach. And I've been doing it now for 10 years using medications.
Wow. Yeah, that's incredible. And it kind of feels like you kind of, I don't know. I've heard people, completely quitting cold turkey, right? But it's so hard to do. And I've heard plenty of other people say that they needed a step down sort of program in order for that to happen, reduce until we're done. And I don't know which one is better at preventing relapse. But it seems like it's not a one size fits all sort of agreement. And so for you to be helping with that's pretty incredible.
That's a good way to put it. It's not a one size fits all. And again, I'm supportive of the abstinence only approach, the Alcoholics Anonymous smart recovery approaches. I'm supportive of all of that. But the way I like to put it is we don't treat heart disease and cancer the same way we did in 1935 when Alcoholics Anonymous was founded. And so I think that we should have alternatives for people that want to reduce drinking slowly or don't want to become completely abstinent. And so I actually work with a number of individuals that the stress of their job, home life stress, whatever gets to them, and they realize all of a sudden they're just drinking too much. They're coming home from work and drinking 3/4 of a bottle of wine in the evening, and they know they shouldn't be doing that. And so we focus on getting them back into a range where they have a healthy relationship with alcohol, with limited drinking. And then if they want to choose to go on to abstinence, we do that. The focus here is not only behavioral techniques like Alcoholics Anonymous, which I'm supportive of, journalizing, and those approaches, direct one-on-one counseling, but it's also the use of FDA-approved medications, and though not yet approved for alcohol use reduction, the GLP-1 medications, which I'm seeing significant impact on my patients' alcohol use with the use of GLP-1s.
So let's start with how do you know when somebody has a problem, when they have a an alcohol abuse sort of addiction. I know that we call it a disease, right?
Yeah. Yeah. Use disorder. There's a DSM, the psychiatric book that the psychologist and the psychiatrist use to determine whether there's a problem. And there is a survey that includes items such as, has your alcohol caused you to give up things you enjoy doing? Has it affected your relationships? Have you put yourself in danger because of your alcohol use? Are you devoting an excessive amount of your finances to your alcohol use, et cetera? So there's that criteria. The other criteria is the Center for Disease Control criteria, which is 15 drinks a week for males and 7 drinks a week for females. I realize that sounds very unfair to the ladies, but based on smaller size and a different physiology, people should limit their drinks if you're male to 15 drinks a week and for females to 7 drinks a week. But I actually use another criteria that I developed over the years, and that is anybody that's drinking more than they want to be drinking. And I've had people come to me that were drinking 12 drinks a week. I had a doctor come to me and he says, I can't be at the top of my game in the operating room if I'm drinking that much. And so I want to get down. And we got him down to 3 or 4 drinks a week. And on the flip side, I've actually had a patient that came to me was drinking 30 beers an evening, going through a divorce, very stressed. Him and his wife were still living together, so he was sitting out in his van in the evening before waiting for her to go to sleep, and he was drinking 30 beers in the evening, and we needed to get him down. And so we got him down into about the 10 drink per week range, a vast reduction using medications. And then he went on and chose abstinence, and he's been successful with that. So as you mentioned, it's not a one size fits all. So I like this approach of anybody who feels they aren't at the top of the game at work, it's affecting their relationships, maybe their home life, they aren't meeting responsibilities, then let's roll up our sleeves and address that and get you where you want to be.
Because it's so accepted, in our society. Like walk around the corner, you're gonna find a liquor store somewhere. Maybe walk far enough and down the sidewalk, and through movies and TVs and books and just everything that we consume from media, like it's just accepted as, hey, you got a hard day at work, go have a drink. Soccer moms go have a bottle of wine at night. That's how you relax from dealing with your husband and kids. But I like that where you're talking about how do you measure it with your functionality. But there are highly functioning, alcoholics.
Yes.
But I think comparing those two, where it's like how many drinks plus how many, or like where are you lacking in your life because of that?
Right.
Seems like a good measuring.
And less is better for nearly all people, because of the long-term effects of alcohol. And I've seen that in the emergency department in terms of the liver issues, the dementia. Dementia is a big one that long-term increased alcohol use can bring on, cardiovascular disease, etc. And so I think moderation, and that's the name of my medical practice, Moderation MD, it is appropriate for a lot of people, and like you said, it's a social thing, and most of the people that come to me, they actually know they're drinking too much, but they don't want to quit completely. They enjoy the social aspect of being able to sit down and have a meal and have a drink with friends and family, and so we just got to make sure that they've got a good handle on that. So when people come into me, what we do is an initial assessment of, what are the issues associated with your alcohol drinking, like we talked about, the DSM criteria, what is the quantity of alcohol you're drinking now? Where do you want to be? How is it affecting your life? And how can we change that to get you where you want to be? And I'm supportive of all the behavioral techniques, and we'll talk about those. The journalizing that's needed,
Mm,
keeping a drink log, for example, is absolutely important in this process. But I think medications have a use, and I think medications are underutilized in the treatment of alcohol use disorder. There are currently 3 FDA approved medications. I actually only use one of those 3 routinely. There's the old medication you may have heard of called antabuse, and it's a medicine that if you take it every morning religiously, then when you drink alcohol, it will make you sick, sometimes
mm.
violently
Oh,
sick.
yes, I have heard of
Yeah,
it. Yep.
nausea and vomiting,
Right.
etc. I've never prescribed that medication. I don't think a punitive approach to alcohol use improvement is the right approach. There's another medicine that is called Campril or acamprosate, and it's a good medication in terms of moderating alcohol use, not a cure-all, but a good medication to help decrease alcohol use. The problem is it requires 2 pills to be taken a day, 3 times a day, every day. So compliance is an issue. People have a tendency not to want to take that much medicine on a timetable. And then the third medicine is called naltrexone. There's an intramuscular form of that where you can get a shot every month, which helps with drinking, called Vivitrol. But I use primarily the oral form of naltrexone. So it's really taking a pill once a day. And I like to use it with a technique that's becoming more and more popular called the Sinclair method and developed by Dr. Sinclair in the 80s. Have you heard of this at
No, how's
all?
this?
Okay, so the Sinclair method is I've been using for 10 years and I found to be effective, not a miracle, but very effective at helping people reduce their alcohol. So this is the approach of the Sinclair method. You're taking naltrexone, which is a medication that blocks the opiate and the serotonin and the dopamine receptors in your brain. So the way to take naltrexone using the Sinclair method is to take the medicine 1 hour before you drink, and it mutes that warm and fuzzy positive feedback response you get from alcohol. And then we concentrate on having non-drinking days. We have people take days where they don't drink alcohol and they don't take the naltrexone. So when you're drinking, you're taking the naltrexone beforehand, an hour beforehand. People have no difficulty remembering to do that, and it kind of mutes that alcohol response. But then on days you don't drink, go out and enjoy your life. Take the dog for a walk, do a workout, go fishing, whatever you enjoy doing, and gear up those opiate and dopamine and serotonin receptors in your brain. And so your brain kind of learns over a period of time that you can have great days without alcohol, and the response to alcohol maybe isn't as great as it once was. And with that technique, over a period of time, people reduce their alcohol use. And I work with a methodology where we set goals. Okay, how many drinks are you drinking to start? Let's say you're drinking 30 drinks a week, not unusual for people. Okay, let's go ahead and target 20 drinks a week here in the first month. And tell you what, let's set guidelines around what's the maximum of drinks you're going to have in any one setting. And you know what, you have problems when you come home from work and the first thing you do is reach for a beer. First of all, you're going to have that hour built in there where you take your medicine, so that's going to be delayed. But let's create a drinking window where let's say instead of starting drinking at 5:30, you're going to push it off until 6:30, and you're going to be done by 8:30. So we use all those parameters, and it's like a continuous quality improvement project where you just kind of you tweak it over a period of time. And that has been very effective. I've been using that for 10 years before the GLP-1s are available, and universally people have success with that. We have them journalize. We have them keep a log of their drinks every day so they can then see what their progress is. And again, this is a very effective approach. So again, I think medications are underutilized for helping people reduce drinking. Again, because we've had this abstinence only approach. You don't need to take medicine because it's abstinence only. And I will make a comment if I can here that, a lot of times, and I don't know what your experience is, so I don't know how you react to this, Ty. but a lot of times, the emphasis is put where there's a profit motive. You know, you go into residential rehab, and that's going to cost you $15,000, or your insurance company $15,000. And people do fine when they're in that isolated setting. They're away from the stresses of home and work life. You know, they've taken some time off work, but then they go back home into their normal setting and they have those stresses. And it's difficult for them to adjust for that. And that's why I think a lot of people have trouble maintaining their sobriety and get into this relapse cycle. That's why I like working with people, you know, in their normal lives. You know, they're continuing to work, family stresses, maybe relationship issues, whatever. But let's go ahead and train you to deal with your alcohol use, you know, while you're in those situations, and we can have success. And that's really the model that my practice has been built on for the last 10 years. And, you know, it's why we've had great success with patients.
Yeah. No, that makes total sense. And, I could see how it works for so many people. So I grew up in a household where my father was an alcoholic. If there wasn't money for anything else, there was always money for beer. And, whenever, he was awake because you heard that can crack open. And you had about 20 minutes of rest before, all hell broke loose. And that was on a daily basis. And in situations like that, where I don't think there's any denying that you're an alcoholic at that point, right? Where it's every single day you're drinking, like the guy you were talking about earlier, he was waiting for his wife to go to sleep so he could drink a 30 pack every night.
Yeah. Yeah.
That's excessive. But for those who say, well, I don't drink all week, but on Saturdays I like to go out to the bar and I like to have, maybe it's over that 15 drink, which is easy to do because once you go have, after so many, you lose count, right?
Yeah. Yeah.
Yeah.
Well, you're mentioning another criteria I did not bring up, and that's a drinking definition. And binge drinking generally is considered to be more than 4 drinks in any one sitting. And so binge drinking is a problem. And so that is dependency. So you go 5, 7, 10 days, but then you got to have 15 or 17 beers at the tailgater, or whatever. Then that's a problem. So we need again to roll up our sleeves and learn how to address that. And I think these behavioral techniques and medication can help. And again, if we bring people down this path and they get to the point where they've limited their alcohol use and it's time to become abstinent, then that's great. Then go ahead and do that. But again, I find a lot of people, and I think maybe a majority of people that have issues with alcohol have the capability of controlling that alcohol without complete abstinence and taking away that social aspect of their life. Quite honestly, they don't want to be the guy that goes into the bar and is conspicuous for not having a drink when he's there with his buddies that he drank with for 15 years. So I think a focus of harm reduction and limiting alcohol use is a reasonable goal. Again, supporting abstinence once if people decide to go that direction. But again, I find the majority of patients that I've had success with limiting their alcohol to where they want to be usually don't want to pursue that route.
So let me ask you this, because you talked earlier about taking those certain days where you're going out, you're walking the dogs, you're enjoying the sunshine, you are working out, you're priming your dopamine receptors in your brain, and realizing, hey, it's okay to have a good. It's possible to have a good day without using alcohol, right?
Yeah.
A lot of these recovery events or behavioral health events and things I've gone to, there's usually a socializing night, or even there's the galas and all that stuff. And so they'll have an open bar, but it won't be an alcoholic bar, right? It's
Yeah.
mocktails and non-alcoholic drinks there. What do you feel about those? Are those useful in maybe tricking your brain into thinking you're taking in alcohol, or what is it to?
Yeah, I think using alternatives like that is a great approach. So yeah, the non-alcoholic beers, the mocktails, I think there's no reason that shouldn't be added to the mix in terms of helping people achieve success. People even taking the very simple approach of you're going to intermix, a beer with a glass of water before your next beer. I think those are all great approaches. There's more than one way to skin the cat, and I think in all of the above all of the above solution is really an appropriate approach.
Yeah, so let's learn about what is the GLP-1 medication that you've been prescribing and how does it work?
So this is, again, I think a very, very exciting area. I'm networking with a few other docs across the country, some leading experts, like a doc I'm working with at a well-known center called the Caron Center, Caron in Philadelphia. They're using actually GLP-1s not only for alcohol use, but for opiate use as well. So let's back up and talk about, how the GLP-1s were developed and how they have found success. So initially, these were medications used by diabetics to lower blood sugar, and they are effective in lowering blood sugar. But the drug companies realized with their use that their diabetics were losing a lot of weight as well. So they went back and did studies to get these medications approved for weight loss. GLP-1s have three primary mechanisms of action. One is they lower blood sugar. We mentioned that, and that's one reason it helps with weight loss. The second is the fancy term is slows gastric emptying, which means it tightens the valve between the stomach and the intestines, so food and drink and alcohol stays in your stomach for a longer period of time, so you feel fuller for a long period of time. But I think the primary mechanism by which it helps with alcohol use is that it affects also the third mechanism of action is it affects the hunger system in the brain. So it acts on the hypothalamus in the brain so that people get satiated related to food, and I'll say alcohol, much earlier than they would otherwise. So initially, I treated a number of patients for obesity with GLP-1s as part of my medical practice. And it was amazing. Patients come back and say, "Hey, I didn't expect this, but I'm just drinking a lot less than I was otherwise." And I think it's primarily because of that hunger center action, but also maybe because of the slower gastric emptying. And the term that I would hear over and over again from people is, "I've just become disinterested in alcohol." I used to go home and I would have half a bottle of wine. You mentioned the soccer moms or the professional women, that have a stressful job. They'd go home and have half, maybe even three-quarters of a bottle of wine before they felt that they could get to sleep. And with this approach, with this medicine, they would tell me they became disinterested. They would pour a glass of wine and it would be half gone and they would forget about it. They would just become disinterested in the medication. So then I got a focus of using this medication in addition to the naltrexone, the Sinclair method, on helping patients with this harm reduction approach to decrease their alcohol. And almost universally, people have success at substantially lowering their alcohol use. Now, I got to say, the FDA has not approved GLP-1s. We're talking about Ozempic and Wegovy and those types of medicines for alcohol use. Based on my experience and with the network I'm doing with other docs across the country, I think this is inevitable that these medications will get approval to help reduce alcohol use. And since naltrexone came out about 20 years ago, we really haven't had any other effective medications. So I think the combination of naltrexone and GLP-1s to use to reduce alcohol use is going to become routine. And I'll also mention there's a way to use these medications that can help avoid the side effects yet still be effective. And that is a term I call microdosing. So everybody's heard about the side effects of the GLP-1s, the nausea and the vomiting, potential more serious side effects like pancreatitis. But what I have found is that if you limit the dosing, if you go into this with your eyes open at lower doses, you can achieve success with avoiding the majority or maybe all of those side effects. So microdosing of GLP-1s, along with naltrexone, along with behavioral techniques like journalizing and setting goals, can be exceptionally effective in helping people vastly reduce their alcohol use. And again, they can stay there with a harm reduction technique, limited drinking, or if they choose to go on to abstinence, then we can go ahead and have them be successful in that manner as well.
With your practice being in that same area for the last 10 years, what have you seen more of? Have you seen people just keep it down to a healthy amount of drinking, or do they go totally abstinent eventually?
Yeah, I have a unique practice in that my patients often self-select in that they come to me because they know this is the service that I provide. A lot of times all the alternatives are going to be, go into residential rehab and be abstinent. And, for people that that's a good fit for, that's good. But I have a biased population and that people come to me because they know that they aren't going to have to get removed from their life, from work and home for a period of time. And we will work with them while they're in their current situation to reduce their alcohol use. So most of them come to me looking for harm reduction, not necessarily abstinence.
So you said there's more medications that are being tested now, and you believe they're going to be approved soon. Is this something that you see, I guess, more research being put into right now?
Yeah, absolutely. I think the primary medications are the GLP-1 medications. I think they will take the majority of the spotlight going forward, along with naltrexone. And I think they're going to be adopted progressively as people realize this benefit. And there are current studies. There's been one down in North Carolina, University of North Carolina now. Controlled study, blinded studies are looking at this to see how these medications affect alcohol use. And the preliminary data is very, very encouraging.
Yeah, it's something new we've never, covered before on the show, and it's something it's vital is looking at what are the alternatives besides, quitting cold is good if you can do it, but not everybody can do it. And once you're in addiction, like I don't think that people on the outside, because it's so easy to look at someone and say, you don't want to drink, just don't drink. Don't pick up the bottle. Don't pick up again. Don't go to the liquor store. But they don't understand what that actual addiction and struggle is like. So maybe a step down method, like what you're proposing here, would be much more, I don't know, digestible, or a mode that they could follow. It's almost like
Right.
being in a program yourself.
Yeah, and you got to be careful with alcohol in terms of the cold turkey approach.
Yeah.
Yeah, a lot of what I've done in the emergency department over the years is manage people that are in alcohol withdrawal, and alcohol withdrawal is dangerous. Alcohol withdrawal kills people. Opiates have gotten all the notoriety over the last 15 or 20 years, and people feel terrible when they're in opiate withdrawal. And the phrase they use is that they feel like they're going to die, but they aren't going to die because opiate withdrawal generally doesn't harm people. They just feel horrible for a period of time. And of course, in my addiction medicine practice, when I've had patients in opiate withdrawal, we manage that with medications to decrease that discomfort. But alcohol withdrawal will kill you. You can have alcohol withdrawal seizures. So there is a significant risk. So that's another benefit to this kind of step down over a period of time approach. You can avoid the risk of significant of alcohol withdrawal and the threats associated with that.
And does your practice work with people that are just local to you, or do you have people that work
So
with
my
you across the
my
country?
practice is primarily a telemedicine practice. It's just like this, us talking to each other. And I'm licensed in Ohio, Indiana, Florida, and Arizona. Can see patients that are located anywhere in those states. And so we usually set people up with an initial appointment. We take an hour discussing what their current situation is, what their needs are, and then we generally progress with the techniques that we just discussed. We usually start with naltrexone. I usually don't start two medications right at once. We start with naltrexone. We'll do that for a couple weeks. Side effects of naltrexone are really very, very, very limited. Had very few people that have ever had a problem. And then we'll add in the GLP-1 at the microdosing amounts, and then we'll encourage, and in fact we check in with them frequently related to make sure you're keeping your journal. We'll set a goal of, okay, how many days a week? We call them AF days. How many alcohol-free days a week are you going to have? Okay. So maybe you're drinking every day to start. Well, we're going to start you with looking at a day or two of alcohol-free days. And, you were drinking 7 drinks a night. Let's make sure we cap that at no more than 5. Okay. And then we progress over the period of weeks and months to get people where they are. And, again, I can take people from 30 drinks a day down to eventually 0 if that's where they want to go. Or if you're just, I have a lot of professional people come to me and they're executives and they just say, I'm not getting things done the way I want to get them done at work because I'm not feeling good in the morning. Well, let's make sure that you aren't drinking every weeknight, and let's make sure on weeknights
Hmm.
that you are drinking, you're capping it at 2 drinks. And then you can, progress in your life and your profession the way you want to. And this is also can be very therapeutic for, of course, as you know, the way alcohol can affect relationships. It can be
Right.
very therapeutic for relationships and home life as well.
Absolutely. Well, Dr. Kolodzik, it's great having you on here. Thank you so much for sharing your expertise and educating us on things that probably we didn't know was available. Something I always ask, guests at the end of the show is, with all of your experience, both personal and you've got over 30 years of, emergency medicine experience. You've got your practice that you've had for the past 10 years, and specifically you're using medications that I think not a lot of people have heard of just yet. What do you think is a long-term solution for people who are struggling with alcohol abuse?
Yeah, I think it's really to stay committed and be smart. Okay, be smart about your approach. If you've had recurrent relapses, then maybe look at a different approach that to what you have looked at in the past. It takes some discipline. You can't just throw a medication at a problem and expect success. But if you work with a knowledgeable provider, somebody that has helped you in this area, that they know the behavioral techniques, they know how to add in the medications, then there's no reason you can't be successful. In fact, I would say my patients have universally been successful. It might not be dramatic right out of the gate, but over a period of time, for those that stay committed, they will have success.
Perfect. Yeah, that's great. Great advice. Thank you so much. And so if people want to find your practice online, where would they go for that?
Okay, so the best way to find me is I've got a couple different websites, but it's just Dr. Paul Kolodzik. It's DrPaulKolodzik .com. I've got my YouTube. I got a YouTube channel with Moderation MD. I'm going to have my new website up with moderationmd.com. Actually, it's going to be themoderationmd.com here shortly. But if you go to the Dr. Paul Kolodzik website, you can go ahead and find me. And I've also had a metabolic health practice that's originally how I got involved with the GLP-1s, helping people lose weight and lower insulin resistance. If people are interested in that, they can go to that, which is at, uh, actually, Dr. Paul Kolodzik is the best one, but Metabolic MDs, Metabolics, MDS.com. And you can find out a lot of information about me and see if this is something that might be a benefit to you.
For sure. And concerning the other things you used to practice, you've got a book out as well, right?
Yeah, I got a book. Again, so the way I got involved with the GLP-1s is helping people improve metabolic health. And that's a big kind of catch-all term, but it really focuses on an issue called insulin resistance. And we don't have to get into the details of that, but I'm actually a big proponent of using continuous glucose monitors, those devices you see on the back of the arms of diabetics, in non-diabetics. They're now available over the counter. And I believed in that so much that I wrote a book about that to help people avoid diabetes. If you're pre-diabetic, you can avoid ever going on to diabetes. So thank you for allowing me to plug the book. But the book is The Continuous Glucose Monitor Revolution, and it's available on Amazon.
It's Dr. Kolodzik. Thank you so much for being on the show. And thank you for listening. If you're watching this on YouTube, you can find us on any of the podcast platforms of your choice and vice versa. If you're listening to this as an audio podcast, you can find us on YouTube. Search for podcast or long-term a podcast in recovery. If you heard Dr. Kolodzik say something here that was important that you think that somebody else should hear this message, the best thing you can do is share this episode with them. The worst that can happen is that they won't listen to it, but the best thing that can happen is that it can save their life. And so there's some pretty powerful stuff that we just talked about here, and some really important information I know that we've never covered on the show. And I don't know if it's just public knowledge just yet. And so let's help spread that message. Share this episode with someone you know needs to hear that. It's the quickest way for us to get the messages to the people that need to hear it and to grow the show. So I appreciate you for being here each and every episode. And thank you, and we'll see you in the next episode.